Good morning and welcome to the Endeavor Health Outcomes Research Seminar and the seventh in our Health Equity and Implementation Science Research Series. Today, we're delighted to have Dr. Susan Nasr from the University of Chicago present her work on trauma-informed care, medical education. This is part two in a series on trauma-informed care in our seminar series. We'll also be joined by an expert panel, once again, including Dr. Brad Stahlbach from the University of Chicago, Esteban Rodriguez from Corazon Community Services, and Dr. Salwin Rogers from the University of Chicago. So I would like to start off and thank all the program directors, leadership, in outcomes research at Endeavor Health for supporting this conference, but also I would like to thank all of our first responders working in our clinics, health systems, and communities to fight the good fight every day to advance health equity for our patients. My name is Sean David. I'm the Vice Chair for Research in the Department of Family Medicine at Endeavor Health. I'm also an Outcomes Research Program Director for Translational Science, and I'm the site lead for the Institute for Translational Medicine at Endeavor. And Rachel Brewington, who is the co-host of this seminar, who is administrative leader at Outcomes Research Network. And Rachel and I will be piloting us through the seminar. So are we at the learning objectives now, Rachel? Can't seem to see the slides. Okay. All right. So the learning objectives for today's seminar are to first define trauma and trauma-informed care. Secondly, to describe the state of progress in medical education on integrating teaching and trauma-informed care. And then thirdly, to name some basic elements that can be used in trauma-informed approaches with patients. Next, Rachel will be sharing a slide on CME events, on CME and Zoom orientation to explain how to navigate the seminar. But first, I want to just call out the fact that this is going to be addressing several translational science competencies. And these include, in particular, the focus on the unmet needs of education of physicians with trauma-informed patient care, to develop some generalizable solutions and cross-disciplinary work to do this efficiently in busy clinics and sensitively at the same time, and to ensure diversity, equity, inclusion, and accessibility in the care, as well as partnerships.
Thank you so much, Dr. David. Hello, everybody. To mark your attendance and claim CME for today's session, text the SMS code on the number listed on the screen. For this live activity, the University of Chicago Pritzker School of Medicine offers a maximum of 1.5 AMA PRA Category 1 credits. Physicians should claim only the credits that match their participation level. Other healthcare professionals will receive a certificate of participation. If you're interested in how these certificates apply for AMA PRA Category 1 credit from ACCME accredited organizations, please check with your professional licensing board. The CME flyer is attached to today's calendar email and will be emailed to you along with more instructions on how to retrieve your CME credit after today's seminar. During the webinar, you'll be muted, but feel free to ask questions or share comments using the chat function at any time, even during the seminar, during the talk. Just remember to consider your audience when posting, and if you have something to contribute to the discussion, make sure to address it to both the panelists and attendees so everyone can participate. Thank you very much. And now Dr. David will go over the agenda.
Thank you, Rachel. So to start off, after introductions, we are going to be going into the presentation, and that will start in about 5 minutes. Following that, there will be a Q&A, and we will be taking questions from comments that you put into the comments section. Rachel will do a Q&A with the speaker, and with member of the panelists are welcome to join as well in responding to those for about 5 minutes. And then about 11:55, we'll start off with the Incubator Hub expert panel, with our expert panelists here today to put into context the work that we've seen presented. It's a very rich part of the seminar, and I hope you can stay for the expert panel as well. Finally, we'll have some closing remarks, and we can go over the few nuts and bolts, like how to send in your evaluations and where to go to find the video of today's recorded presentation. So I would like to introduce Dr. Susan Nasr from the University of Chicago, where she's a clinical associate professor in internal medicine. And with no more delay, I'm pleased to turn the stage over to Dr. Nasr to begin her presentation.
Hi, everyone. Just give me a minute to share my slides. Okay. All right. Is everyone seeing slides right now? Yes. Okay. Fantastic. I'm Susan Nasr. I'm a clinical associate in internal medicine at the University of Chicago. And I'm going to be talking about teaching trauma-informed care. Not all of this is my work. A lot of it is a summary of others' work. I'll be making it clear when I'm talking about anything original that's coming from me. All right, so who am I and why should you listen to me on this topic? I did my residency at a county medical center in Oakland, California. It was a very underserved population and largely uninsured population. I joined the faculty at University of Chicago in 2018, so I've been working there for about 6 years. I practice clinical medicine, both inpatient and outpatient, and I have a sub-practice in trauma-informed care where I'm getting referrals from other specialists who feel like they need an especially trauma-informed primary care physician to take care of their patients. I write curriculum in trauma-informed care, and I've taught residents and faculty both locally and nationally. An overview for this talk. So I'm going to give you just enough on trauma-informed care so that you can understand what I'm talking about when I start talking about medical education. I will give you a state of affairs and where we are in teaching trauma-informed care in medicine right now. I will give you a little piece of how I teach trauma-informed care, and then we'll get to research needs, which I hope will plant a seed for later conversation, and then we'll wrap it up. So when answering the question of what is trauma, I usually start with the adverse childhood experiences study, which is now decades old. The importance of this study is that I think it put trauma on the map for primary care providers in particular. And the link that it established was between childhood trauma, risky health behaviors, chronic disease, and even early deaths. Now, the way that they were defining trauma, which can be different from study to study, and it often is, was physical or sexual abuse, neglect, extreme poverty, or a parent impaired by a substance use disorder or a severe mental illness. And this was a retrospective study of 17,000 patients, largely Caucasian, largely middle class, all insured by Kaiser, and asking about exposure to these childhood experiences and then health conditions now. And what they found was that at a cutoff of 4 or more exposures, didn't matter which of these they were, people were twice as likely to develop this particular risky health behavior of smoking, and 2 to 4 times more likely to develop coronary artery disease, strokes, COPD. And practicing providers have seen how this leads to early death. So this can help us understand how, even if we're looking at adult health, something that happened in childhood can be relevant. The thing is that our definition of trauma has grown greatly since the 1990s. And now you can see how many times this graphic has been updated. And you can see that we're barely fitting on the slide now. Adverse childhood experiences are just one part of what can constitute a traumatic experience for our patients. And I think it's important when you're taking care of a community to ask yourself what types of trauma are most common in my community, because this will help inform what a trauma-informed practice looks like for you. I can say on the south side of Chicago, for example, unconscious bias and racism affect our patients deeply, may affect their experience of the medical system, and community violence is also quite common in our population. And then you can also see that social and behavioral determinants of health are also on this map. Trauma can happen on multiple levels. So on an individual level, as in I was in a car accident, between people, as in my partner harmed me, or the often overlooked group of collective trauma, which is things like unconscious bias, racism, systemic and structural trauma, which absolutely affects our patients. And there are no questionnaires on this, but you better believe this affects our patients and their relationship with us. If you're looking for a formal textbook definition of trauma-informed care, here it is. This is from SAMHSA, and in shorthand, it's referred to as the 4 R's. First R, realizing the widespread impact of trauma. Second R, recognizing signs and symptoms of trauma in patients, in our colleagues, in ourselves, responding to that with policies and with our clinical practice, and then seeking to resist re-traumatization of our patients and our colleagues. When I teach trauma-informed care to internal medicine residents, I tell them that trauma-informed care is specialty dependent. So in primary care, I tell them that we need to ask our patients what they've been through. We need to make our clinics safe places for our patients, and we need to have our interactions feel safe. And then we need to respond to what our patients have been through, particularly when we feel like these experiences, no matter when they happen in the patient's lifetime, when we feel these experiences are affecting our patient's health now. Couple notes on this. Response does not have to be a therapy referral. And asking is not asking someone to retell their trauma story. People's trauma stories belong to them, and they get to decide if and when to tell their story. Okay, so how are we doing in teaching all of this? Not so great, and there have been studies on this. This was a study of 200 medical students. This was of first through third year students, and it was asking about, and it was in a single medical school in Georgia, and it was asking about knowledge of trauma-informed care. So 16%, only 16% of all of the medical students had heard of trauma-informed care at all. This was pretty recent, so the surveys were done around 2021. This is a different study, different system. So this was at least a couple medical schools across the Midwest, now first through fourth year students, asking different questions. asking about, do these medical students know how to ask about adverse childhood experiences or ACEs? And maybe half of them did, but half of them did not. Of those students who did know how to ask, most of them did not know where to direct a patient for help. And this is actually not surprising because I feel that a lot of practicing clinicians do not know where to direct a patient for help. Is the situation any better in residency? Not really. So different study asking family medicine residents in a single program. This study, I want to go back to this one. This study was blinded as to the purpose of the study. The other studies were not. So going back to the residents, 80% of the residents felt that it was important to screen for adverse childhood experiences, but 55% knew how to do it. Are we doing any better in clinical practice? Not really. So this was a survey of a medical system in the Midwest, unnamed medical centers, and all of the providers. So this is now residents and practicing physicians were asked questions about trauma screening. Most of them had not heard of the Adverse Childhood Experiences questionnaire, and only 3% had used that questionnaire in practice. Now, if you are looking at this and you're saying, I don't know what the Adverse Childhood Experiences questionnaire is, not to worry, I'm going to show you right now. This is what it is. Let me make my screen bigger so you can see it all. Okay. So this was adapted from the original ACEs study in the 1990s to include some other aspects of childhood trauma. And in the simplest form, it can be given to a patient to fill out. The part down here is something that's been added. Do you believe these experiences have affected your health? And this gives the person an opportunity to say if they feel like these experiences from long ago are affecting them now. What I'll implore you to do is if you give this question to someone, do not give it to them and put it aside. Studies have been done about this questionnaire, and patients who are given this questionnaire want you to follow up in some way to acknowledge what they've said on it. And even if that is just one-on-one in the office, acknowledge what they've been through and what they've confided in you about. That is an important completion of doing this form with someone. What to do about this knowledge gap? What I can say is that for each white box on the screen, there is a paper showing efficacy of using this method to teach trauma-informed care to medical students. So all of these have been shown to be effective in some form. There's no coordinated effort to use any single one of them in medical school training or in residency training. The one coordinated effort that has happened has been to establish medical student competencies, and this is relatively recent. So anyone who's done a medical student evaluation before will be familiar with this format of going through domains of clinical practice and understanding someone's skill level under that domain. And so what this group did was they used a panel in 4 different centers. The panel included medical educators, it included patients with lived experience, it included medical students, and it included topic experts to vet what would be useful competencies for useful skills for medical students to have. So examples are just demonstrating knowledge. Can the medical student define trauma and resilience as terms? Can the medical student recognize a traumatic stress response in a patient? Under professionalism, can the medical student describe examples of intrapersonal and systemic bias and how they might traumatize or re-traumatize patients or our colleagues or staff members in our offices? Can a medical student respond to a patient's trauma disclosure with empathy and compassion? Now, these are competencies, they're not curriculums. So this is simply what to evaluate the medical student on. It does not explain how to teach these things. Nonetheless, this was rigorous, and they made 43 competencies under the eight standardized domains of clinical practice. And if you want the paper, there it is. It's open access. Okay. What do patients say? Let's not leave patients out of this equation. What do patients say? Patients who have had traumatic experiences say they want from their providers. This was a study of 300 patients in a safety net clinic in Colorado. It was pretty diverse, a mixture of English and Spanish speaking patients, 20% African American patients. All of them had all of them reported 4 or more adverse childhood experiences, which, as we talked about earlier, is linked to health outcomes. And they were asked, what would you like your provider to do before a doctor's visit? How would you like your provider to respond if you report a stressful or traumatic experience? And the things I'd like to call out are 76% of the patients wanted the provider not to change. So they wanted the same MD each time they saw a provider, or the same PA, or the same APN, or the same resident. They did not want to switch between providers once they had established a trusting relationship with one. They wanted providers to ask permission before doing a physical exam, and they wanted providers to explain what was happening during the exam rather than having the provider descend upon them and do the physical exam with no explanation. And how they wanted to be helped. Most commonly, people were requesting a therapy referral, and better yet, if it were at the clinic. A lot of FQHCs are already set up this way. University of Chicago is set up this way. So in theory, it doesn't look like a clinic would need too much rearranging to accommodate some of these requests. Making the provider the same every time, I can imagine people shouting a little bit about that one. But some of these are not so hard to do. More patient perspectives. So this was a survey of 100 patients, also another safety net clinic. This was a largely Latinx population, and these patients were asked about individual interactions with their providers. And 80% of the patients said it was okay to be asked face-to-face about a trauma history by their primary care providers. 85% were fine filling out a questionnaire like the ACEs survey, or like the PC-PTSD-5, which I'll show you later. And then discussing that survey, not leaving it hanging. 70% expected you, as their primary care physician, to know what to do with their responses. And 70% were okay having you, the primary care physician, report what you've been told in the patient chart. What I would say is that on an individual basis, it makes more sense to ask individuals permission about what they would like reported in their chart versus not. Okay, now I'm going to teach you trauma-informed care in 5 minutes. This is what I call TIC light. And this is generally how I teach I personally teach trauma-informed care to residents. I always say that the first aspect of teaching trauma-informed care starts with self-care. So statistics being what they are, more than half of the people listening to any talk on trauma-informed care have been through a traumatic experience, childhood experience themselves. And so medical students, colleagues, any person might feel triggered by topics discussed in a trauma-informed care lecture. And I always invite people to do what they need to do to take care of themselves during the talk or afterwards. And when we teach residents, we put some faculty go-to points available for residents to go to if they're feeling not okay after the talk. That some faculty that will help them navigate our system in order to get any help that they might need. Okay, so the rest of these are, although they are my personal practice of teaching, they are also on the medical student competencies. So they're not coming out of nowhere. Universal precautions, what are these? Universal trauma precautions are, if you decide that you do not want to screen all comers for traumatic experiences, then maybe the best practice is to assume everyone who walks through your door has been through a traumatic experience and adjust your practice accordingly. That is all that universal trauma precautions means. One of these precautions might be changing how you do your physical exam. So how do we do a trauma-informed exam? This is not something that will take a lot of time or change your practice dramatically. I'm going to argue that it's a lot of nuance that makes a big difference. So there's published literature on this too, by Sadie Ellisu and colleagues. And this was in fact a curriculum for first-year medical students on how to do a trauma-informed exam, broken down into what to do before, during, and after the exam. So before the exam, we're all busy clinicians, but it's helpful to look at your patient's face before you do the exam. Do they look terrified? If they look terrified, it's time to slow down and address what might be written on their face and what they're not saying. Explain what exam you're doing, why you're doing it, and what the steps are. For example, I do a lung exam in all patients that report cold symptoms. I'm going to listen to your lungs in the front and the back, and you'll feel a cold stethoscope on your chest. Then the patient knows what to expect. Ask them if they have any concerns about the exam before doing it. Ask them if they're feeling comfortable, and remind the patients that they're in charge. So I do this in particular before sensitive exams like GU exams or breast exams. I tell the patient that you're in control of this exam. So if you would like me to slow down or stop, please give me a wave. And then offer a chaperone. Would you like someone else to be present during this exam? During the exam, you want to keep the person covered as much as possible without compromising the quality of your exam. It's helpful to change your phrasing so that you're asking permission rather than ordering someone. So can you please sit on the table rather than sit on the table? Stay within the patient's eyesight rather than standing behind them so they can see what you're doing. Use simple language and check in with them during the exam. So one way that we commonly phrase our check-ins are by telling patients how they're doing. Like, you're doing great. You're doing so well. And the patient might not be doing great during our exam. And so I've changed that question to, how are you doing? And I give the patient a chance to answer. Prepare patients for sounds and sensations. So for example, the stethoscope will feel cold, or you'll hear the speculum click as I open it. You'd be amazed by how much of a difference it makes when the patient knows what to expect and is not surprised by these sounds and sensations. It takes away a lot of fear and establishes a lot more trust. Changing your language can also be quite helpful. One thing that I'd like to banish from the medical lexicon are the words "for me." So can you sit on the table for me? Better just to say nothing. Can you sit on the table? Referring to tables as tables rather than beds. When we're doing pelvic exams, instead of describing stirrups, which I will give you, they look like stirrups, describing footrests instead. And then instead of giving our patients judgments or compliments about how they look, instead of saying looks good, say looks healthy or looks normal. Then after the exam, thank the patient, let them get dressed, then come in, let them get dressed and sit in a regular chair, and then come in and discuss results with them, and then ask them if they have questions. I think all of us mostly do this, with the exception of possibly allowing the patient to get dressed, because when we're rushing, we often want to give our feedback to the patient and move on to the next patient before they've gotten dressed. Moving on to trauma screening and what I call a case finding approach. So universal trauma screening is not yet nationally recommended. The USPSTF gives a grade B recommendation to screening childbearing aged women for intimate partner violence and for screening all adults for depression and substance use. As of 2018, they say there is insufficient evidence to recommend screening for trauma exposures. And that goes for adverse childhood experiences, that goes for PTSD, that goes for trauma in adulthood. And they say so because they say there are a few studies in men. They say there are a few high quality retrospective studies on benefits and harms, and there are no randomized controlled trials on benefits and harms. So what do? We've known since the 1990s that these experiences affect our patients' health and their health outcomes. So is there a way that we can look at our patient's current health and go backwards and ask, when do we think a trauma history might be relevant here? And here are some suggestions about when to do that. So if your patient has refractory depression or refractory anxiety, what they really might have is PTSD, and you may be treating them with an ineffective approach. If you're treating someone with refractory pain, you might consider that this pain is more of a somatic experience of trauma. I'm not saying that everyone with refractory pain is in this boat, but it's something to consider. Patients with behavioral issues with you or in your clinic may actually be having a dysregulation or what we call an outside of their window of tolerance experience in your clinic, and may actually just be very afraid. Patients with uncontrolled chronic conditions or who avoid procedures and screenings, or who are systematically irritable and blaming with you, the provider, or who no-show to clinic quite frequently, might have a trauma history interfering with their current health care. So how do we ask our patients about this? So when I speak to my colleagues about trauma screening, they want validated questionnaires. What has been validated in the literature? So this was validated through the VA, has 2 halves. It's called the PTSD-5. It is specifically for use in primary care. It's short, First half screens for trauma exposure, second half screens for PTSD symptoms. So first half, sometimes things happen to people that are especially frightening, horrible, or traumatic. There's a list of examples. Have you ever experienced this kind of event? Yes, no. Then the second part is symptomatology. Generally, the categories of nightmares, avoidance, hypervigilance, detachment, or inappropriate guilt or inappropriate blaming. And 3 out of 5 gives a 78% sensitive, 87% specific cutoff for clinical PTSD. How do I ask? So here we are going away from evidence and into personal practice. I screen all of my patients for trauma exposure. I'm a primary care physician. I do this on first meeting, in the social history section, when I am asking about smoking and alcohol, I also ask about trauma exposure. And here is how I say it. I ask everyone this question since trauma is common and matters for your health. You don't have to answer the question if you don't want to, and I don't need to know details. I've chosen my words very carefully here to normalize what I'm asking, to explain why I'm asking this question, and to give patients an option to opt out. Then I ask if they've ever been harmed sexually, physically, or emotionally as a child. I wait for them to answer. Usually they're saying yes, no. Then I ask as an adult, yes, no. And then because of our particular population, I ask, a lot of our patients have lost loved ones to violence or had traumatic interactions with the police. Has this happened to you? Yes, no. How do we respond if our patient says yes to any of these questions? A lot of people believe that patients will become extremely dysregulated after answering these questions, and we will need to spend half an hour trying to calm them and ourselves down. But this has not been my experience with this question at all. This can be contained pretty easily. So people just want to know that you believe them, that that they did not deserve what happened to them, and that you care about helping them now. So thank you for telling me. I'm sorry that happened to you. It shouldn't happen to anyone. Do you think what happened to you is affecting you now? May I offer some information? May I offer some support? That's it. I generally try to avoid the words counseling or therapist, only because those are loaded words for some of our patients. But this is truly enough of a calming and containing for most patients. Okay, so we're now changing gears, moving on to research needs. What is the most efficient way to integrate trauma-informed care teaching into medical school curriculum? Since what we have now is a very fragmented approach, what is the most efficient way to train practicing physicians so that the preceptors of medical students and residents know what these medical students and residents are talking about when they're talking about trauma-informed care? I want to bring up California because as far as I know, this is the only state that has a state mandate for universal screening in Medicare and Medicaid patients. And that gives the opportunity for a case control study to be done with patients and health outcomes before and after the universal screening mandate was put in place. If the USPSTF is calling for high quality retrospective studies on the benefits and harms of universal screening, then how do we construct those? And if randomized controlled trials to establish benefits and harms of screening can't be done, how do we address the USPSTF call for that level of evidence in order to make a recommendation? And then conclusions. So overall, I think our awareness in the medical education world is growing about the need to teach trauma-informed care, but there is little teaching actually happening. The lack of a national recommendation or USPSTF recommendation is a barrier to getting this, getting curriculum written off the ground and systematically integrated. We need an organized effort to integrate trauma-informed care into our medical training. Please, integrated, not fragmented. There are published best practices on this. And I'm hoping that after listening to this talk, you will feel that making your practice trauma-informed is not as hard as you thought it was. And happy for questions and discussion.
Thank you so very much, Dr. Nasr. That was very interesting as a full-time patient, not a physician. It's very interesting that those things are even happening and that there is a push to push those types of sensitivities in the clinic. So that was really interesting. Let me share my screen. Okay, we do have one question. We'll now go over any questions that are put in the chat. Please, everyone, if you have a question, go ahead and put it in now. One question is, for patients with serious somatization who have declined therapy counseling services, how useful is it to try to identify the details source of the problem in childhood?
Yeah. Yeah. If people are not ready, they're not ready. If they're not ready to discuss a link that you think is there, then they're not ready. And the best thing you can do is to continue, if you're a primary care physician, is to continue to have that trusting, supportive relationship. And one day that patient will be ready. Just like, you know, you have patients who have smoked for years and years and years, and you've talked to them for years and years and years about it, but one day they decide, you know what, for whatever reason, I have now decided that it's my time to quit, and now I'm ready to listen to you, doc, about how are you going to help me.
Thank you so much. I'll pause for any other questions that might pop in case I missed anything. She said the patient in question has been her patient for 35 years. So.
Thank you, Dr. Burnett. Yeah. You know, it begs the question of, is there something going on in the doctor-patient relationship that the patient's not feeling okay about, or has what has happened to them has happened to them so terrible that they cannot talk about it and they cannot acknowledge it. And those cases are really tough. I think I don't have a uniform answer for what to do. I would say sometimes talking about, you know, sometimes things that happen to people are so bad that in order to survive, they can't see it. And I'm telling you as your provider that I feel like I can see it, but I can understand how for you you might not be able to see it right now or ever, and that's okay with me. Let's figure out how to set some common goals for your health, and see where you get. And it may not be it may be not far, which then begs the question of, does that patient need to switch providers for just a change in dynamic? I don't know.
Hey, thank you so much. I'll encourage everyone, even if not right now, to please put your questions in the chat and we'll make sure to field them at a later date. And hopefully Dr. Nasr can give some feedback on them later. But if that's all the questions we have right now, let's move on to our expert panelists and our incubator hub panel. Thank you so much.
Thank you, Dr. Nasser. That was very powerful. As a primary care doctor myself, one of the reasons I wanted to have this seminar is because I don't know what to do. I certainly don't want to do any harm. And yet there's clearly such a need for trauma-informed care now more than ever. So this is an incredibly, has a lot of utility for all of us listening, but I really thought that was great. Thank you so much. So I would like to introduce our expert panel. And we have an esteemed group of experts in the community and through their scholarly work. And they include Dr. Brad Staubach, who is Associate Professor of Pediatrics and Clinical Psychologist and in Pediatric Psychiatry, Developmental and Behavioral Pediatrics at the University of Chicago. And he's also Director of the University of Chicago Medicine REACT program and co-founder of Healing Hurt People Chicago. Mr. Esteban Rodriguez, MPA, is Executive Director and CEO of Corazon Community Services. It does a tremendous amount of work in the community with families who've experienced trauma. And Dr. Selwyn Rogers, Professor of Surgery at the University of Chicago, also Executive Vice President for Community Health Engagement at the University of Chicago, and he is a founding director of the Trauma Center and Chief of the Section of Trauma and Acute Care Surgery at the University of Chicago. So thank you very much. So I'd like to, reflect on this wonderful presentation and start off by asking the question to our panel: how can we implement results from what Dr. Nasser talked about today? Certainly, you have, Dr. Nasser, done some evaluations, I think, of educational outcomes as well. So there's some data from a lot of what you just taught. How do we apply this to advance health equity in our health systems? And if any of you feel free to start with your thoughts about it.
Well, I'll go ahead and start. I think that one of the things I love about listening to Dr. Nasser talk about this subject, and I've had the pleasure of doing that before, is that there's a way that making this part of your universal approach to all patients and doing it in such a thoughtful way can both be helpful to the patients. It can also provide data about how the need, what the need is, and how the need is or isn't being met. And so one of the areas where we are sorely lacking equity is on supports for recovery from trauma for our patients. There are very few resources given the demand and the need that's out there. So if we were screening our patients in the way that's been described and providing support to our patients, as Dr. Nasser has talked about, that could be used within our systems to say, this is a need that our patients have. This will, addressing this need will not only make our services, our systems more equitable, they will also improve patient outcomes and reduce unnecessary utilization of our services and thus save money. So I think that this work can contribute to more equity in that way.
First of all, thank you, Dr. Nasr. I think the first time hearing you, and I think just hearing the presentation, I'm hopeful and thankful that there's individuals, physicians specifically, who are doing this type of work in their day-to-day practices. And I think as a community base, grounded and rooted in the community, we don't hear that often, especially in communities where I'm come from and where I serve and support. When we hear the word equity specifically tied next to health, our community is already not involved. They're not enthusiastic about just having conversation. There's the lack of trust that our community has with health systems, right? So those are components. So throughout my questions and responses, I'm going to be coming from a community lens and perspective, in the sense that this is what people are telling us and how we're trying to address and hold work with them. We're not physicians. We don't have nurses. We don't have clinics. We don't have behavior specialists. We're just people that live in the same neighborhood that they live. And we have this trauma-informed conversations and trainings and certifications that we focus specifically on teachers and our parents, to just learn what trauma is. So obviously, the addressing social determinants of health is are factors in creating equity in the health system. But often what is not being talked is like, what are those social determinants of health, and how come we don't do more as a health system, right? Therefore, we won't. The way I look at it is, you invest and support more upfront. You don't have to focus in the back end of work, right? Us as a community-based organization, we focus on housing, we focus on education, employment, we focus on the quality of the air, we focus on violence, we focus on food disparities, and we often see that no health institutions is helping us on the ground as well. There's a few grants here and there, but it doesn't do justice to the level and attention that is needed for this type of work. I think in the greater schemes for health equity and health systems, we lack the data collection. And without the data collection, we are lacking the resources allocated to that. So for us as a community base, community engagement is something that will fulfill this equity conversation, is partnering with organizations on the ground and co-creating solutions together, where we don't see ourselves as treatment organization, but we do preventive work. How is it that we're focusing on the issues, and for us, our medicine, our treatment is relationship building. One of the key components of mediating trauma is a high social network or high social relationship base. We often say that a person with high ACEs, but with high networks or relationships, are less of a risk than a person with no ACEs and also no networks or relationships. So that's where we come in, and we want to build community. So we just want to be part of that system and equity solution. So thank you again, once again, Dr. Nasr, for a beautiful presentation.
I love those comments. Thank you so much.
Yeah, I do too. And I wanted to ask you both, Esteban and Dr. Solbach, what do these kinds of partnerships look like when they have been effective? I think that you are both interact as an example of an academic community partnership. Is that something that is scalable? Is it something that you've seen in other places too, other systems?
So in my experience, when we are able to create those kind of partnerships, they are very small, and they may impact a small number of people. That often community organizations that we might partner with are themselves under-resourced, and so if we don't bring resources with us to partner with them, then it makes it very difficult to partner in a meaningful way. So when we think about scaling, I mean, I think it comes back to whether our systems have resources and choose to use their resources in this way. But I think a lot of the work that we do, especially around trauma, is most effective when we have a clinical and community component to it. And so just in terms of trauma-informed care training, this is related, but not exactly on point to your question. But when we do trauma-informed care training, we have a team that includes patients who are survivors of trauma, survivors of violent injury. So they're former patients, and they are teaching the medical personnel about, from their perspective as a patient, what does it mean to provide trauma-informed care? And so that's an example of a partnership with members of the community as opposed to like a community organization. But typically, providers who participate in that kind of training see that as the most valuable aspect of the training. They really like having that opportunity to hear directly from patients. And sometimes the way the patients explain it is actually much more helpful than sometimes the way that we as academics might explain it. And there is a publication on this approach that I can put in the chat. I don't think I can put the actual article, but I can put the reference. So if anybody's interested.
Great, thank you. So it seems to me that residents, that Dr. Nasr, that's a good place to think about. Maybe not a place to start, but hopefully we are recruiting empathic medical students who are going to have the ability to listen and to be responsive and authentic with their patients and try to help. But then the skill sets you're talking about can be taught in the wards, that can be taught in clinics, that can be taught in ERs. And absolutely that's happening and at some of our institutions. But nationwide, there's just we've seen this with COVID during the lockdown, and a lot of the studies that have tracked people, the amount of depression, anxiety, and the disproportionate weight of that in communities of color, working on the front lines and that kind of thing. There's no shortage of trauma out there. There's like, and so how do we think big about something without losing the quality and sensitivity? I'm really keen to know what that would be, but it seems to me that things like Epic, do they build this in? Are there packages that are automatically query this? Is there Medicare meaningful use for, to health system to get paid to ask these questions? And then are there ways to show that it's more cost effective to do discharge planning around this too? So it's big challenge, but wicked problems. But at the same time, I'm encouraged to see that this can be taught, and it needs to be taught the right way with the right partnerships. So Rachel had a comment too, as a question. Are any of you privy to what barriers exist in making trauma-informed care education mandatory, recommended for residency medical training programs nationally? Dr. Nasr mentioned it is not currently recommended. I was thinking the same kind of thing, but I didn't know how to state the question so eloquently. Where is GME, ACGME, and some of the national organizations on this?
Yeah, they're not there. There are a lot of there are national organizations that are on board. So AAFP is, and some of the other sort of national professional organizations are. But as far as the ACGME is, it's not on board yet. Although now that there are written competencies, that might make it easier to adopt.
47, right? You got 3 or 4 years to learn those. Yeah, absolutely. Do you think that's likely to happen soon? That becomes normalized and built in?
Well, I think it could happen in a couple of ways. One way is that we could see some positive results from California, and this could happen sort of state by state. Another way is the USPSTF could reevaluate the data and come out with a different recommendation. And in that case, I think the ACGME would immediately adopt this as a necessary training, because if we are screening, then we need to understand the care. How fast the ACGME is going to adopt this, I really don't know. But in absence of those things, I really don't know. Maybe in the next 5 years.
Thank you. So, kind of building on this, we can't really talk much about what our health systems can do without bridging to the community. So, and that takes resources and time and investment and trust. What kind of policy change do you think we need to be able to enable more of this expansion of education and systems that support the social determinants and the mental health care that needed to do this? Do we need more funding for this? Is this about reimbursement? Is this about needing a national strategy? Where would you like to see things go in terms of policy?
I'm always hopeful, and this is way out of my realm of expertise. Again, community perspective. I think the social determinants of health screening and intervention towards it is an ideal tool that community individuals can utilize if exposed to. I always talk to our individuals about who their physicians are currently and how they are being treated and how they're being talked to. And often is not as an individual, to the point where I challenge individuals to seek institutions that are viewing their holistic health. So again, perhaps not a policy change, but it's definitely something that can promote their own individual health and care by just seeking professionals that are looking and providing screenings and providing resources above their day-to-day check-ins or the treatments that they're going for. I always emphasize about a physician or doctor clinic should have a resource table that goes above health topics, right? Housing, food, work employment, or youth programs, anything that can support and complement their direct treatment. Again, not policy change, but more individual institution changes.
So, yeah, so if, let's say, there is a reimbursable SGOH trauma-informed care service referral, and then maybe that you have that kind of model happening at University of Chicago, but where like the major payers will pay for that. Are the social workers and most mental health care professionals trained in trauma-informed care? Would that get us there if people have the kind of or do they also need to have more training in this area?
Yes, it's a great question. The reimbursable referrals are typically for PTSD, like
Mm.
clinical PTSD. Um, I think I think there needs to be an effort to triage what we're seeing, and so some people on one end of the trauma spectrum just need a trusting relationship with their primary care physician, and that is therapy enough. And some people will not get better unless they're seeing a therapist for prolonged exposure therapy, which takes a lot of time. And we as primary care physicians need to get better at sorting out which direction to send people, just like we do for other specialists.
Yeah.
We know which patients with asthma can do fine with a rescue inhaler and yearly check-ins with us, and we know who needs a pulmonologist. So we need to get better at triaging our patients so that we don't overburden the mental health system.
Interesting. Asthma as an example makes you think about, staging different levels of asthma and different interventions based on evidence. But also, I guess, removing the re-exposures that happen when somebody, can't feed themselves or their family, or it's too dangerous to walk to school or clinic, or um,
Yes, people need to feel comfortable having that conversation with their physician, or the physician needs to ask and then address the problem somehow or try.
So, thank you. The next question really has to do with where do we need to go with the science here, and this issue of retrospective studies and doing community-based participatory research, that kind of thing. We're learning a lot from communities about needs, but where do we, can we do more to move the needle on methods of conducting research? And this is a big, broad area, but there's sociome data commons development. There's a lot of informatic opportunities. What are your thoughts about, since you are all engaged in scholarship and advocacy, where to take the science next? And so RCTs of these interventions, large scale, maybe Kaiser could do something like that, or maybe NIH could. Yeah, I don't, outside of PTSD, but more on this issue of addressing trauma specifically.
I think for us, we're at least more in the direction is we all have heard of the landmark study of ACEs, but there's also adverse community environments, which talks about community impacts such as poverty, right, food deserts, poor housing conditions, unsafe neighborhoods and parks. There's also adverse circuitry expressions, which is like risk factors such as autism or people in the brain diversity spectrum that is often not talked about either. And our culture exposure as well, adverse culture exposures, which is like racism, sexism, classism, the isms in the world, and how all of those are a package deal in conversations. And it's not just the landmark study that we all know and familiar with.
So am I hearing that there's plenty of we know enough to start acting now and coming up with solutions? Do you think we need to learn more, or learn from what we do to try to address these health gaps?
I know Dr. Nasr said about there's not a scientific or data specifics to implement this at a larger scale, but you don't have to get a white paper or a research document that tells you how trauma impacts health disparities, right? It's clear. The death gap by Dr. Ansel is an example of how that is being spilled in the community. We often say if you were to have all these different factors, you're Black, you have autism, you're poor, you were experienced violence towards your mother, would you rather be that person? And nobody raises their hand. So those are, and see how that correlates to their adult health outcomes. And so the data is there. It's just I
Yeah.
don't know what else
Yeah.
is needed for these institutions to implement it and create this national requirement.
Thank you. So, if we wanted to just start, it sounds like you have some good tips, Dr. Nasser, that we could begin to kind of build into medical roundarounds, other things to get residents thinking this way, to get attendings as well. But is there a place we should go to come up with some of those tips that you brought up? Is that paper?
Yeah, yes. So if you go to, there's a organization called TICER, it's an acronym, TICHER, and it's a collaborative of people interested in education and research on trauma-informed care. From that website, there are links to all kinds of ready-made educational materials on trauma-informed care. There's a ton out there already. And using that as a jumping off point is going to be really helpful.
Either?
TICHER, TICER.
Okay, great. And then there's a comment from Sonia Sultan. I think this research part, the research part is key. Only CMS can move the needle on causing a high-level policy change regarding this. Putting the onus on individual health systems is doable, but slower to implement. Having worked with CMS for rulemaking in the past, I know that CMS needs to cite the research extensively. If the research is lacking, they cannot propose a policy. So I suppose there's a lot of ways to address this too, with meta research, with research synthesis and so forth, to begin to put together a corpus of data CMS would need. But it sounds like it would be helpful if there were some new studies.
I am hopeful that quite a few new studies have come out of California.
Okay.
I'm not familiar with that literature yet, but I think the meta-analysis idea is a good one, especially to address the need for high-quality research in order for there to be policymaking. The mandate in California came from the governor, so it came from top down instead of from CMS up.
Excellent. Yeah, and the Preventive Services Task Force looks at they do meta-analyses, and they look at that as some of the highest level of evidence. Well, let's see here. Are there any other comments from the panel before we move on to begin to wrap up?
I just think this whole question about the evidence, what is the evidence for this, is a challenge. And it also begs the question for me, are there RCTs that have been done on other basic screening questions that physicians ask, or are they just presumed to be common sense? And I don't know the answer to that. But the challenge with doing an RCT on something like this is identifying the outcomes that you would be looking for to support doing this. And a lot of times these outcomes are not immediate. So, I mean, we may be able to show that it didn't do any harm, but to show the ways in which it improved their health is more challenging. So I don't know what the solution is, but those are just some thoughts.
Yeah, because it would be hard to show mortality benefits unless you had a huge study with lots of follow-up, but then there may be functional health status types of promise scores and things like that that could be tracked, right? I do know there were some RCTs of social support and things like that that were done looking at some of these outcomes decades ago, but it's not quite the whole picture that you're talking about. Okay.
And I know that the original authors of the ACE study have done some work and shown in one study that screening for ACEs was associated with a reduction in emergency room utilization. But I think that there were a lot of questions raised about that study, about other variables that weren't looked at or controlled for, and what that correlation actually meant, if it was truly a correlation. So, but I know they have done that, and the CDC is a good, the CDC website is a good place to go to just see what all has been done with the ACE study over the last couple of decades.
Excellent. Thank you. We didn't talk about this today, but then in childhood incarceration and long-term effects of that on experiencing violence is going to be part of a seminar coming up in a couple of months as well. So, well, this has just been incredibly enlightening for me and powerful, and I appreciate so much all of you, the work that you do, and for participating today. So, thank you for joining us today. For questions, comments, concerns, or requests to present at a future seminar, please contact me. My email is listed on the slide. If you could all please take a brief survey regarding today's presentation, it would be very appreciated. You'll be directed to a site after you close out of the window, and the link is also in the chat box. Let me just double check that the link is there. Yes, it is for the survey. And thank you, Rachel. And yes, so our seminar series will also continue on Tuesday, October 15th, same time, same channel, on the topic of treatment declination, racial ethnic disparity, and breast cancer survival. And lastly, the recording of today's webinar will be distributed in a few days. Okay. Excellent. So, any final comments, Rachel?
Nope. I just unmuted to say thank you again.
Yeah, thank you. Thank you all so much. And there's the information for the survey. If you have a chance and you're still on, go ahead and do that, but we'll follow up by email with details and a link to the video. So until next time, we thank all of you and thank you for joining us today. And I learned a lot, including how much I don't know about what how to do this right. But I appreciate that we've got some great pointers and experience, and we really need this kind of seminar. Thank you all so much. Okay.
Thank you all.